Hello everyone. Today I'll be talking to you regarding electrolyte imbalance or disturbance. It is one of the most confusing topic, and this is the one topic which is asked throughout the world, whichever exam you write, whichever specialty you write, everywhere sodium potassium are to be involved. But don't worry, I'll make it very simple. At the end of the class you'll find will be your fingertips. Okay, so first I'll be talking to you regarding sodium disorder. Okay, sodium disorder. Question number 1. We have an elderly male who has a history of breathlessness for last 2 weeks. Past medical history include type 2 diabetes, depression, ischemic heart disease, and at the moment heart rate, respiratory rate is 26, saturation is 94, and the tongue is moist, lungs, and there are some crackles on the lung base on auscultation. There is no edema periphery. Blood test results are as follows. You can see WBC count is little raised. Sodium is 128.2 noted. Potassium is 5.1. Urea, creatinine are almost slightly on the higher side. Serum osmolality is urine sodium, and that is 50, and chest X-ray shows the left lower lobe opacity. Now, what's the most likely cause of his hyponatremia is the question. The answer of this question is SIADH. The other options are hyperthyroid, chronic kidney disease, Addison disease, and salt-losing nephropathy. So question is about hyponatremia. So how to approach a case of hyponatremia? Approach to a case of hyponatremia. But before that, we should know what is normal serum sodium. Normal serum sodium is 135 to 145 milliequivalent per liter, or we can also write millimole per liter. Same. The reason being, sodium has a valency of 1, so milliequivalent or millimole are same. Okay, this normal level. So definitely when the level goes below 135, we call as hyponatremia, and the level goes above 145, we call as hypernatremia. The very basic thing that you should know. The normal range is 135 to 145 milliequivalent. So now the question is, we are getting a case of hyponatremia, that is the serum sodium is less than 135 milliequivalent per liter. How to approach this case? So you got a report, just like the way we got a report right now. We are getting a sodium is 128 per minute, is definitely less than 135. How to approach this case? So friends, first thing, when we are talking about hyponatremia, we got to know what is the fluid status. Underline this word, fluid status of the body. That means how much water is in the body. It may be hypovolemia. That means the volume is less. Volume of the water in the body is less. U-Volumia is normal volume, and hypervolemia means excess volume of water in the body. Okay, so this is very essential to know all these things, because these three are going to influence the diagnosis. Diagnosis changes depending on how much is there. So with this small background, now you are going to ask me question, sir, how to find out the patient sitting in front of you, whether it is low volume or normal volume or hypervolemia? Well, simplest thing, in this, tongue will be dry. In these two, tongue will be moist. So I made your work very easy. You got a report of hyponatremia, you ask the patient to protrude the tongue. Tongue is dry. Well, it's a hypovolemia. Right, so we ruled out. Now the rest too, where the tongue is wet, then how to differentiate? Very simple. In where the volume is increased, they have a edema of feet. Edema. Very simple. It means the golden line to remember. So golden line to remember is, here is tongue dry, you can write down dry tongue. This is edema, dry tongue, edema. And no edema and tongue is moist, this is euvolumic. Very simple. To simplify it, look for the tongue, dry tongue, hypovolemia. Look for edema, it is hypervolemia. No dry tongue is moist, no edema, you are dealing with euvolemia. This is the first thing. Now, one more question for you. Suppose, a question for you, all of you. Suppose in the body sodium is less. It can lead to what? Bony problem. This is rank number 1 getting question. Gold medal question is this. Write down the answer in your copy. What bony problem can occur in a case of prolonged hyponatremia? Of course, that is understood. Prolonged hyponatremia. I am sure by now you have written the answer. Answer is, this is the bone are prone to fractures. Okay. With this background, we move further. So, how to approach a case? This the gold medal worth $1 million line is this. I'm giving you a flow chart worth $1 million. And if you know this chart, you can very comfortably answer any question. So we are getting a hyponatremia. Now hyponatremia, it could be hypotonic hyponatremia. Write down this word. This can be hypotonic hyponatremia. Written, yeah. Now what do you mean by hypotonic? We have a low serum sodium. Yes, we know we are talking about hyponatremia. Low serum sodium, understood. But low serum osmolality, this is hypotonic. Got it? So what I am going to discuss right now, we will be having low serum sodium and low serum osmolality. And this line, what I spoke, you could understand 70%. 30% I'll be discussing in the coming slide. Then you will understand completely the meaning of this hyponatremia, hypotonic. Okay? Because we will be having something to discuss later on where I will be having hyponatremia, but with increased osmolality. Of course, osmolality. And this is so-called pseudohyponatremia. Pseudohyponatremia. This is a golden line to remember. Golden line to remember is this: increase serum osmolality. Of course, both are in serum. Decrease serum sodium, but increase osmolality, pseudohyponatremia. And this is so-called where we have a low serum sodium and low serum osmolality. This is so-called true hyponatremia. As of now, I'll be talking about true hyponatremia. Yes, we understood. So, as I told you, we determine the volume. Volume here means extracellular volume, which I mentioned in the previous slide. Okay, now here also I have to tell you some basic concept regarding fluid in the body. This is the cell. Whatever fluid is there inside the cell, it is intracellular. Definitely inside cell is intracellular. Any fluid which is outside the cell is extracellular fluid. This is intracellular, extracellular fluid. Definitely true. But why it is so important to talk? Now this extracellular fluid can be in two places. This is intracell, inside a cell. Now there is a blood vessel and there is an interstitial space also. So when we talk about extracellular fluid, it is maybe in the between the cells, so-called interstitial space. Or it may be in the blood vessel. Blood vessel. That means in the blood, whatever fluid is going in, is flowing, is all extracellular. So now we are clear about that when I talk extracellular fluid means either interstitial space or blood vessel. With this background of understanding two things, intracellular and extracellular is further divided into interstitial and the blood vessel. So-called blood volume also you can say. We come back. So friends, extracellular volume, it may be reduced, we call as hypovolemia. It may be hypervolemia when it is more than normal, and it is normal, we call as U-Volumia. EU stands for U-Volumia. This point I mentioned in the previous slide. And I told you that in hypovolemia, one classical clinical finding is dry tongue. And in hypervolemia, we get edema. Dry tongue plus edema plus hair. No dry tongue, and no edema. So clinically simple, and these three things you can see in any patient. Patient sits in front of you. Just imagine in your own body. Feel, just focus on your tongue. It is wet. Okay. And just focus on your leg. There's no swelling. That means U-Volumia is fine. Simplified version. So now I'll take one by one. Well, hypovolemia I'll talk. In hypovolemia, total body water is reduced. Note it down. Total body water is reduced. That's why it is the hypovolemia is there. But total body sodium is reduced much more. Much more. Write down. Total body water is reduced, but total body sodium is reduced more than that. So in such cases, we measure urine sodium. We measure urine sodium. Okay, done. Now wait. Let's learn something more. As we just understood that in this total body water is reduced and sodium also lost. So if I asked you very broadly, by which route, main two routes by which we lose the water and sodium both, that is by GIT, classically by diarrhea, vomiting. And second route is kidney losses. There are two main losses by which water goes out with sodium. So now to know whether it is GIT loss or kidney loss, history will be there. But however you want to document, if it is extra-renal loss, that is GIT burns, we know in GIT in burns also a lot of fluid loss. Urine sodium will be less than 30 millimole per liter. 30 millimole per liter or maybe 30 milliequivalent per liter. But if it is a renal loss, then it will be more than 30 milliequivalent per liter. Got it? So if I have to tell you the summary of the hypovolemia, the first point is, now you answer the question. First point is, what you will look for the tongue. Tongue will be dry. Simple dry tongue, you are dealing with hypovolemia. Okay, hypovolemia. So in hypovolemia, what are the two main routes with hyponatremia, with hypovolemia? One is GIT, one is kidney. What you will check? Urine sodium. In GIT losses, urine sodium will be less than 30. In renal losses, it will be more than 30. Very simple. Okay. Well, in the renal losses, diuretics are common. Diuretics are common. Very common cause. We use furosemide. And there is one thing called CSW. It is cerebral salt wasting syndrome. About this I'll be talking in great detail, but just now in cerebral salt wasting syndrome, what we call as CSW, there is a renal losses, the urine sodium will be more than 30. Is clear to you? Yes. Now we talk about hypervolemia, where we have edema of feet. Yes. In this, total body water is much more increased and total sodium is also increased. Point to be noted. Total body water and sodium both are increased, but water increase is more and sodium increase is increased but comparatively less. And in this is seen in condition like congestive heart failure, chronic liver disease, congestive heart failure. CLD is chronic liver disease and nephrotic syndrome. Write down full form. I have got less space to write. So in edema, I told you classical edema, and in this case, if you check urine sodium, it will be less than 30. Less than 30. So friends, hypervolemia, the blood fluid is much more than the sodium increase, total body water increases, but total body water increases much more than the sodium. With the result, edema is there and urine sodium is how much? Less than 30 milliequivalent per liter. We understood? So this is simple, and now we talk about the most important is U-Volumia. In U-Volumia, this we see classically in case of SIADH. We see in SIADH, okay, what happened? No dry tongue, the tongue will be wet, no edema, that very comfortably at a glance only in 2 seconds, you can pick up that you got a lab report. Patient come to you with a lab report, serum sodium is less. What you ask? Show me your tongue. He shows tongue, you look wet. That means no dehydration. Then you look for the edema feet, no edema. By this only you can diagnose that I am dealing with U-Volumia, U-Volumic. So let's learn how. And in U-Volumia, the total body water is slightly increased, but total body sodium is normal. Point to be noted. Total body water is little increased, slightly on the higher side, but total body sodium is normal, and that is so-called SIADH. Okay, and in this, if you check urine sodium, it will be more than 30 millimole per liter. So very simple. So friends, urine sodium in hypovolemic type variety, we are getting 2 variety. With the in extra renal loss, the urine sodium less than 30. In renal loss, it is more than 30. In edematous state, urine sodium less than 30, and this we are getting more than 30. It's simple. With this background of this, we'd move on to primarily I'll discuss SIADH. Now in our case, there is no edema, and this tongue is wet. Straight away we are confirmed. Very simple. We are dealing with U-Volumic hyponatremia. Very simple. So friend, U-Volumic hyponatremia, the golden line to remember is what? No edema. I am repeating this line so that it goes deep into your mind, you don't forget. and tongue wet. This you can write, tongue is wet. Very simple, very simple. With this background, we are very clear that we are dealing with SIADH, right? Yeah. Now we come to question number 2. We are getting a 59-year-old man. 40 pack year history of smoking is there. Now he has come with altered mental status. He had a lot of cough, worsen over months. Dizziness, feature of dizziness is there. He now confused. Today doesn't make any sense at all. He's totally confused. And otherwise, normal neurological examination. That means there is no paraplegia, no hemiplegia, no cranial nerve palsy or any other palsy. So everything is, as far as neurology is concerned, except altered mental sensorium, neurological examination normal. Okay. And they have ordered the test. The report are, sodium is 120. Plasma osmolality is 250 and urine osmolality is 360. Plasma osmolality is reduced. Urine osmolality is increased. Serum sodium is reduced. Potassium, they are all normal. They are all normal. Okay. And checks X-ray reveals a mass in the right lung. Head CT scan report is pending. What is the finding we'll be getting in this patient? So if you look into this patient, so we are getting a very heavy smoker, 59 year, and he has come to us with altered sensorium is there, right? Nothing else is given, but only thing what they have given is hyponatremia is there, and there is hypo oscar n. Even plasma osmolality is reduced, but urine osmolality is increased. This finding what they got in. So the answer of this question is normal extracellular fluid volume. Why this the answer? Why not others? What are the findings? Let's move to greater knowledge. So as I mentioned, the normal serum sodium is 135 to 145. Okay. Now, in SIADH, which we have learned so far, it is the U-Volumic Hyponatremia. U-Volumic Hyponatremia. This needs a lot of understanding. So let's learn the basic concept. Basic concept. I have a glass. It contained 100 ml of water. It has 100 milligram of salt. How much is the concentration? 1 milligram per ml. Definitely. So simple calculation. Now what I do, I add 100 ml water more. Volume become 200 ml. But the total salt is same as 100 milligram. Total salt is still the same, but the concentration goes to 0.5 milligram per ml. So here the sodium concentration has gone down, not due to low sodium, but excess of water is there. So that's why we are getting hyponatremia in this case, right? So we are very clear about it. Now, sorry. Now, let me discuss some basic physiology also. This is the nephron. In the normal physiology, we know that in the collecting duct, we have a anti-diuretic hormone ADH is there. Okay, ADH is there, anti-diuretic hormone. It acts on the collecting tubule and it absorbs only pure water. It only absorbs pure water. It has nothing to do with sodium. And the normal plasma osmolality, is between 280 to 300. This is normal. Some books even have written 275 to 295 also. Some variation always occur in the books, but by and large we'll go by that 280 to 300. And the aim of ADH is to maintain the plasma osmolality in the normal range. Suppose the plasma osmolality goes very high. This typically occurs in summers. In summers, especially in the subcontinent country where a lot of heat is there, we tend to lose a lot of water by sweating. Plasma osmolality goes high. The body will try to secrete more and more ADH, and that will try to absorb more and more water. And so the plasma osmolality is normal. That's why in summer, that's why in summer we tend to pass less urine. We all tend to pass less urine because of increased ADH which comes and urine volume goes down. Now suppose the plasma osmolality has come to 280. The body will secrete less amount of ADH. Less water reabsorption at this, body will try to lose more and more water. That's why in winters we tend to pass more urine, because in summer we were trying to lose the water, large amount of water from the skin because of heat. But here in summer we are not losing, so now less ADH and water goes out. It's quite common in those places like in North India. You sit in the OPD in summer, okay, and same patient, when the winter start, a lot of patients come to you. Doctor, nowadays I'm passing lot of urine. Have I developed diabetes? Quite common in general population. They think passing more urine means diabetes. Then you have to explain. No, it's not diabetes. It is just a change of season. Of course, you do blood sugar checkup to rule out diabetes, but by and large you can say, okay, the clinical applied means ADH concept is there, understood. So we learn. So now suppose, so this is normal physiology. Suppose that somebody, patient's plasma osmolality is 280. So what we expect normally, the ADH level should be very, very low. Yes, ADH level should be very, very low. We don't want water at all. But despite having 280 plasma osmolality, if body secretes still more and more ADH, means more water reabsorption. More water going into the body will lead to what? Hyponatremia. Same example, this 100 ml water coming into the glass is equivalent to increased ADH. Increased ADH is causing increased water reabsorption, and this is going into the body, and that is going to the body, and that is going to cause hyponatremia. So one thing we have learned so far, that in SIADH, it's the water problem, is not sodium problem, although we call it to be hyponatremia. Understood. But now definitely a question is arising in your mind, and I know the question. Sir, you told it is U-Volumic hyponatremia. Okay, but here the volume has increased. So this doesn't fit into the category of U-Volumia. How can you explain the U-Volumia? Yes, that is the advanced stage of this point. So as of now, we learn that what we learn in SIADH, how much is the total body sodium? Normal. And number two, we call it to be U-Volumia, and this due to the volume is normal or slightly increased. Although we call it to be U-Volumia, but volume is slightly increased, is not totally. But in traditional, we call it U-Volumia because there is no edema feed. Sir, explain to us. We have confused. This extra 100 ml water has come to the glass, which has reduced this sodium. Explain how it become U-Volumia. Yes, this is $1 million question. Let's talk more. I have got one glass, 100 ml water, 100 milligram of salt. Okay, and I add 25 ml water more. Water become 125. Sodium is still 100, and this lead to hyponatremia. Understood. Okay, 100 ml of water. The water become 125 ml. Salt is still. The sodium concentration will go down. How much? 100 milligram of the salt. 100 milligram of the salt and 100 milligram of salt is there, and 125 ml of water is there. Okay, 100 milligram of salt. Let's say my mathematics is not very good. Let's say it is 0.75 milligram per ml. Let's presume. Okay, we medicos have a poor mathematics, so definitely it is less than the normal. Now we call something extra. Friends, this is the same nephron. Now I'm going to tell you how U-Volumia occurs. We know that ADH is there, that we learned. But we also know that we have a aldosterone. It causes sodium absorption with water. Yes, sodium is absorbed actively and water follows passively. This is done by the aldosterone. This is normal. So now in SIADH, excess of ADH, and that lead to excess of water reabsorption, and that lead to increase intravascular volume. This lead to increase intravascular volume the way in the previous example. In the previous example, we added 25 ml water more and it became 125. The volume has increased. Agreed. Same thing here also. Now this has increased. The example but I give you 125 ml. Now this increased intravascular volume will go and reduce the level of aldosterone. This increased intravascular volume will go and cause suppression of aldosterone. Now aldosterone level will go down. Okay. Now aldosterone level go, and remember aldosterone absorbs both sodium and water. Now both sodium and water will go out. Both will go out. Remember, I said 2 sodium were absorbed and 2 molecules of water were absorbed by the aldosterone. Simplest example I give you. Now, if I go by this example, that ADH has caused increased 25 ml water absorbed. Now, if I remove from this glass, if I remove 25 ml of the water and if I remove 25 milligram of salt, now how much water is left in this glass? 100 ml. From 125 it has come back to 100. U-Volumia. U-Volumia. Initial was 100. Salt, it is 100 and now it becomes 75 milligram. So this how it has become U-Volumia, and Hyponatremia is there as compared to so-called volume. So there is comparatively slightly excess of this. Just to give example, slightly excess of water is there as compared to sodium. But I just to give you a simplified version I gave you, but slightly, it's not absolute term, it's not U-Volumia. It's slightly on the hypervolemia, but not up to that level that it is going to produce edema. So there is relative, so slightly more water, almost in the normal range of total sodium salt is there, is the concept of SiADH. So friends, increase ADH, the pathophysiology of SiADH, increase water reabsorption, and that causes expanded volume of the expanded volume is there, or what? Expanded volume of the plasma volume, and that lead to what? That lead to reduce renin, and that lead to reduce aldosterone. There is reduced renin and there is reduced aldosterone will be there, and that lead to natriuresis. With water also. Net result is reduced serum sodium, reduced plasma osmolality, no edema, and no hypertension. This is the net result. This is what we get in SiADH. This is what we get in SiADH, net result. Reduce serum sodium, reduce plasma osmolality, no edema, no hypertension, the net result of what we get in SiADH. Okay? So friends, now if you look into our question, what our problem? There was the reduced serum sodium, there is reduced plasma osmolality, that we got it, and urine osmolality is increased. Why? Because more and more water has been reabsorbed, and that lead to increased urine osmolality. The osmolality concept I am going to discuss in the coming slides. So as of now, what we learned that in case of SiADH, hyponatremia is there, and eureka and reduced plasma osmolality is there. Okay. Well, question number 3. We are getting 54-year-old man, and he has been referred because he is having nausea at home, tired, and no other systemic complaints, and he was started on a new medication by his family physician. He doesn't know the name of the drug. He drinks about 3 liters of water per day, that is almost in the normal range, and his skin turgor is normal, oral mucosa is moist. What is the meaning? It is not a hypovolemic. Okay. Heart rate is 80, BP is on the normal range, and blood test 3 days back 127, today is 125. It is going down. Potassium is almost in the normal range. Urea is again the normal range. Creatinine is again in the normal range. That means the main problem is about sodium only. Agreed. Hyponatremia, that we got it. And we also got that the tongue is moist. Fine. Well, this was okay. Now additional tests were also done today. TSH normal is normal, and plasma osmolality is slightly, it is reduced. We are getting hyponatremia and we are getting low plasma osmolality, urine osmolality is high. I think now by your basic concept, golden line to remember. The golden line to remember is, if you remember the basic concept, that golden line to remember, if we are getting hyponatremia, reduce serum osmolality, increase urine osmolality, we are dealing with SIADH. Most likely, most simplified version. When you get a question like this, long question is there. Look, sodium osmolality, increased urine osmolality is SIADH. Very simple. Golden line to remember, but we'll talk more to make your fundas more clear. Okay. So now the question is, this abnormality has occurred, which seems to be a case of SIADH. But which drug? His family physician started a new drug about which he doesn't know. That means we should know what are the drugs which can lead to SIADH. Answer is amitriptyline. So let's learn what are the causes. So first we learn the lab parameters, which really help. Although a good amount of information I gave you, but I still want to give you a concise at one place lab report, although has been given. So the lab finding that we get in SIADH, what happened to sodium? Hyponatremia. Agreed? Urine osmolality is increased more than 100. Remember, hyponatremia means sodium less than 135. Urine osmolality more than 100 milliosmol per liter. Point to be noted. Decrease serum osmolality less than 280. Now how much normal? 280 to 300. The point what I mentioned to you, these three are almost virtually most important thing by which we can diagnose SIADH. Simply the entire SIADH is squeezed in 3 words. Hyponatremia, reduce urine reduce uric plasma osmolality, increase urine osmolality. That's all. SIADH. In addition, there may be slight reduction in BUN and uric acid because of plasma dilution. Remember, I said, again repeating third time, that although SIADH is considered as a case of U-Volumia, in fact, it is not absolutely U-Volumia. There's slight increase in plasma volume, but it is related to sodium. Even total body sodium, although we say it is normal, it is not same, slightly reduced in relative term. But why we call U-Volumia? Because there is no edema feet. So anyway, and potassium bicarb are normal, and increase urine sodium more than 30 milliequivalent, but I told you earlier also. So these are lab finding. I hope you have written it. A quick recap. So you have to answer. What happened to serum sodium? Reduce. What happened to plasma osmolality? Reduce. What happened to urine sodium? Increase. What happened to urine osmolality? Increase. Very simple. This is the lab finding. So again, one more lovely comparative flow chart to make the things easy. Serum sodium normal is 135 to 145. In SiADH it is reduced, less than 135. Urine osmolality 280 to 300, it is less than 200. Normal urine sodium is less than 20. Here it is more than 30. Normal urine osmolality less than 100, it is more than 100. That's all. This is the end result of SiADH. Dear friends, if you know this very simple, you can answer any question on SiADH. Okay? So I hope by now you have written the slide also. Now, little bit more about a very commonly asked question. You get one patient of SiADH. You have done all the lab parameters. And a very commonly asked question throughout the world. What test you do? You go for water loading test. Okay. So, patient of hyponatremia has come to you and you diagnose that he is a case of SiADH. And you want to do it. You go for water loading test is done. How it is done? You call the patient in the morning, empty stomach. Okay, patient has come to you, empty stomach, and you give him 20 ml per kg body weight. Let's presume his body weight is 50 kg. You ask him to take 20 ml multiplied by 50,000 ml. He has to drink water 1000 ml in a span of 15-20 minutes. Nobody can drink in a one go. Okay, he takes in 15-20 minutes, glass by glass. Okay. Then in normal, the patient, a normal person, if he takes 1 liter of the fluid, and he'll be passing at least 90% of the water. That means in the next 4 hours, the patient will, normal person will pass about 900 ml of the water. But in this case, it will be more than, but in this case, the amount of water come out will be less than 900. Let's say he secrete only 700 ml of urine comes out. Normal 900. Okay, let's say you are a normal person beyond doubt. You take 1 liter of water in the next 15-20 minutes. Sorry. In the next 4 hours, you will be passing more than 900 ml of the urine. But in a patient who is suffering from SiADH, the amount of urine will be less than 900. Like, for example, I give 700. So that is simple OPD procedure by which we can come to know that we are dealing with SiADH. And now, if you want to, what the most accurate test? Serum ADH level. Serum ADH level are increased in these cases. More so. So point to be noted, if the question come to you, what is screening test? This is a screening test. They talk about screening test, water loading test is done. But the question is, what is the most accurate test? ADH level. And what happened to aldosterone and renin? They are reduced. So now you have to answer the question. If you, and at the same time you keep on writing question, only few words. If you know SiADH is in your tips. In number 1, what happened to serum sodium in SiADH? Reduce. What happened to serum osmolality? Reduce. What happened to urine sodium in SiADH? Increase. What happened to urine osmolality in SiADH? Increase. What is the best screening test? Water loading test. What is the most accurate test? Serum ADH, which is increase. What happened to serum aldosterone and renin level? Both are reduced. Very simple. So these are 7 points you got to remember. SiADH is your tips. Now, before I go, now I must give you a beautiful chart which will make your fundas very clear. That is, write down. This is aldosterone level and serum renin level. Serum renin, serum aldosterone. What happened in Cone syndrome? Cone syndrome is primary hyperaldosteronism. Aldosterone is increased, renin level is reduced. What happened in secondary hyperaldosteronism? This is seen in conditions like chronic liver disease, congestive heart failure, and nephrotic syndrome. And if I ask you, in which category we studied in the category of hypovolemic hyponatremia. You remember? Yes. In this case, both are increased. Now, in SIADH, we studied on the category of U-Volumic hyponatremia. U-Volumic hyponatremia. In this, both are decreased. Then we studied about Addison disease. In this, we get low level of aldosterone, but renin level is very, very high. Friends, this is a simple table worth $1 million. Worth $1 million is a slide. Comparison of aldosterone and renin. I can again give you a wider picture. So in Cone syndrome, so primary hyperaldosteronism, increase aldosterone and reduce renin. And in secondary hyperaldosteronism, they both are increased. In SIADH, both are reduced. In Addison disease, aldosterone is reduced, but renin level is increased. Beautiful summary. And with this basic concept, you can answer any question throughout the world. Friends, knowing basic is the most essential thing to get success in any exam. So with this background of basic concept about SIADH, now let us see what are the causes where we can see SIADH. Certain cancers. There are, if you see the list in any book, the huge list is there. Do we need to remember all the way? No way, nobody can remember. But don't forget small cell lung cancer. Don't forget, of course there are many other cancers, don't forget everything, but don't forget small cell lung cancer. Number one, head trauma. Head trauma is the second condition. Third is infections. Third is infection, which can be pneumonias. We saw in one of the previous questions where the patient has come with cough, some haziness of the opacity was there, which was indicating pneumonia. It was the pneumonia, I think it was perhaps question number 2 if I remember correctly. Okay, it was the pneumonia which caused SIADH, pneumonia, any infection, including HIV, vascular CVA, head injury. Of course, head injuries, vascular is be stroke, and out of this also subarachnoid hemorrhage. Very, very important. Don't forget this. Don't forget this. Don't forget trauma. Don't forget small cell lung cancer. Then we have a neurological condition. metabolic like porphyria, hypothyroid, very, very important. So in this slide, if I have to tell you what you should not forget, small cell lung cancer. If you forget, if you forget this, it's a big crime. Because in 90% question of SIADH, they will be talking about small cell lung cancer. Head trauma, it has a special meaning because same entity will be leading to cerebral salt wasting syndrome, which is again a cause hyponatremia. So it has a special relevance in relation to cerebral salt wasting syndrome, which I'm going to discuss soon. Vascular is subarachnoid hemorrhage, pneumonias, then hypothyroid. 1, 2, 3, 4, 5. There are 5 keywords which you don't have to forget. Now we come to certain drugs which can lead to. Drugs also, huge list is there. But what you should not forget is vincristine. Desmopressin is nothing but it's a ADH. It's a synthetic form of ADH. Definitely, if you are giving extra amount of ADH, it's going to cause drug-induced SIADH. Carbamazepine, very commonly asked question, tricyclic antidepressant. Of course, list is huge. I have given you 5, 7, but out of these also don't forget these 4. Very, very important, which can lead to SIADH. Okay. So in our question, what I told you that we have a patient was taking amitriptyline. So it was a tricyclic antidepressant, which is causing all other drugs mentioned in the option answer. None of them is a cause which causes SIADH. So friends, this is a summary that you don't have to forget. This you don't have to forget. Hypothyroid, small cell lung cancer, subarachnoid hemorrhage, meningitis or any infection, and of course head trauma. You can add head trauma. To the list you can add trauma or head injury, whatever you can write. You can write head injury. Okay? Head injury. HI stand for head injury. Drugs, vincristine. So don't forget, this is a single most important slide. So this slide and the previous 7 points regarding investigation, if you know, you can answer any question on SID. Here also, this is the very, very important, okay, very, very important, and here also tricyclic and vincristine. This slide also I have further simplified for your easy remembrance. 86-year-old gentleman, unwell, increasing confused, and examination normal, sodium low, potassium, urea are almost in the normal range. The only finding is low serum sodium. One thing we have noticed in the previous question also, everywhere the CNS examination is normal. You examine neurological, CNS examination is normal, but patient is getting confused, and the only finding what we are getting is hyponatremia. So now let me explain to you why altered sensorium occur in the patient, or rather I can say how the patient of hyponatremia comes to us. To write down the clinical features of hyponatremia. Patient may be asymptomatic. No symptom at all. Okay. Now it has a relevance. I told you hyponatremia means less than 135. So, not only it depends, the clinical feature depend on the sodium level, but it also tell how fast how fast hyponatremia has developed. How fast it has developed. What I mean to say, suppose there is one patient whose sodium has suddenly gone to 130 from 135. It will produce symptoms. Symptoms plus. This is sudden, but there is another patient whose sodium has gone to 126, but gradual. He may be asymptomatic. So what I want to convey the message is, sodium has 130, suddenly symptomatic. 126, slow, asymptomatic. Oh, I can give you a day-to-day example. There's one gentleman who is standing on the first floor and he wants to come down. He is in a hurry. He jumps from first floor. And there's another gentleman who is again standing in the first floor and he come by the staircase. Do I need to tell you who will get injury? Definitely the one who was in a hurry to jump. He's jumped and they're definitely going to sustain some fracture or extra. Exactly same, you understood. He had the problem. He has come down very fast but injured. The one who came by staircase, no injury. So this you understood. Done. Now suppose the patient has developed symptom. What symptom he will develop? Why? There is always altered sensorium. Is the main altered sensorium. And second problem is seizures. There are the two problems which can happen in this. Let me explain you the basic concept why this happen. This is the brain cell. Brain cell is there. This is the blood vessel, and here the sodium has gone to, sodium level has reduced. It has gone to 130. So there is what? Definitely reduce osmolality also, reduce plasma osmolality. So here water will leak out. It will go to the third space. Water has come to third space and now it enter the brain cell. So ultimately water from the blood vessel has gone to the brain cell. And of course the brain cell is getting more and more water. I don't need to tell the illustrious student who are listening to me, the cell size will be increased. It is just like day-to-day example. There's a balloon is there and it is already air there. You push more air, the balloon will become bigger in size. So this increased size is there. Remember, the brain is enclosed in a fixed bony cavity, but cells are getting expanded. There's no place to expand. So that lead to increase so that lead to cerebral edema. Cerebral edema occur due to what? Increase in the size. So that can lead to increased size there and hyponatremia. This induce seizures and the altered sensorium. But even it is important to talk about altered sensorium. But what is more important, the sodium has no major effect on the cardiac conduction or tissues. That's why in hyponatremia there is no arrhythmia. Sodium has mainly CNS manifestation, no arrhythmia. Why it is so important? Because these arrhythmias are due to potassium disturbance. The potassium disturbance lead to arrhythmias and all these, but I'm going to discuss it later on. But one thing, again, your concept made very clear that why hyponatremia leads to more of a CNS problem. Okay, and remember, only seizures and cerebral edema, no focal deficit, no paraplegia, no hemiplegia. Okay, so we are clear about it. So we up to this only, when before we look into the option, we learned lot of new thing, and now we are clear about the confusion and the low sodium. We move further in this question. So now plasma osmolality is what? It is reduced. Urine osmolality, oh, it is increased. Urine sodium increase. Oh, now things are very simple. Your basic concepts are very clear. So what's the best treatment of this thing? Fluid restriction. Why? Again, go back to the basics. Go back to the basic. We learned in the very early stage that we have a case of SIADH where the volume is slightly on the higher side. Let's say 110 ml is the volume, and let us say 90 milligram is the salt, right? So patient has hyponatremia. Maybe patient has no symptom, but hyponatremia is there. We are to restrict water intake. Let me say patient has sodium of 130 milliequivalent per liter, and I asked him to restrict the water intake. So total sodium remain as it is, and now he's not taking water. So we have reduced water going in the body, agreed. But one more thing you got to know, we all are losing water. We are losing some pure water via maybe sweating, depending on, even in the winters. It is the January month going on. It's a cold, everywhere it's cold. Okay, especially in the northern hemisphere, it's very cold, right? But still we are losing some little amount of sweating also, but little, not very high as compared to summer. But we are definitely losing water via talking also, via breathing also. We lose some amount of water. So pure water going out, the pure water goes out, this sodium will automatically come back to normal. Sorry. The first step is to restrict the water intake. Water losing, sodium level will automatically come up. I don't think I need to repeat the basic concept. So yeah. So less water, sodium concentration will go up. It will always the first step to be used. Okay. Well, this is especially when the patient has just mild fatigue, malaise, and hyponatremia is there. Of course, in the initial stage of no symptom or at the maze, fatigue, malaise can be there. Reduce the water intake, patient will be all right. Okay. And one more thing, in edema and hypertension are not the feature of SIADH. That makes the work very easy for physician to treat. Because if there was edema, there was hypertension, then we have to do something for this also. Thank God these are not the finding in SIADH. Now, how to treat a case of SIADH? I made a broad statement that it may be acute SIADH or chronic. Acute means the level of sodium have fallen suddenly. First treatment, whatever it is, water restriction is the first finding. Write it down. First treatment is water restriction. Restrict the water intake, and that will take care a good amount of hyponatremia in the next 24 to 48 hours. But this is done when the patient has the problem of mild fatigue, malaise, otherwise no symptom. But severe hyponatremia, what is the definition of severe hyponatremia? If it is less than 120. If 120, and these patients usually, when the patient goes to that level, 120, they usually have symptoms by this. Usually they have symptoms, maybe they have seizures, maybe altered sensorium. So other way around, he may not ask this one broad statement I made. Examiner may ask you, he may not ask. He will say, yeah, there's one patient who has come with altered sensorium or he's having seizures. Okay, and serum sodium is 120. How will you manage? Step one is always fluid restriction. But now he's having seizure also, he has altered sense or altered sensorium, whatever it may be. Then you have to consider hypertonic saline. Hypertonic saline is 3%. Normal saline is 0.9%. This is 3%. So we are giving hypertonic saline. Yes, this will take care of these problems. Again reminding that we give this only when the patient has severe problem, seizures. Okay, now one more question. Suppose the patient is asymptomatic and serum sodium is 120. Will you give hypertonic saline? No way. No way. We have to go by symptom. But definitely when the patient is having seizure and all this and altered sensorium, sodium level will be low. That is understood. Okay. But what is the single most important? This infusion should be very, very slow. Very slow. Okay. That means you give saline that sodium level should not increase more than 0.5 to 1 milliequivalent per liter per hour. That means right now it is 126. Okay. And now you give maybe suppose this is 8 a.m. Then at 9 a.m. it should be 126.5 or at the most 127 at the most. So it should be rather 0.5 to 1 only. Never give fast that by 9 a.m. it become 132. No, no way. Never. Give very slowly, very slowly. The single most important, give slow. But why? Why to spend so much of time in emphasizing that don't give fast? Because if you give rapidly, it can lead to osmotic demyelination of the pons, and patient will develop quadriplegia. The patient will develop quadriplegia by osmotic demyelination if you are getting sudden increase in the sodium level. We understood. So now the chronic hyponatremia. Okay, chronic hyponatremia, when you say it is more than 72 hours chronic, then again the principle remain the same. Always less than 8 milliequivalent per liter per day. Now you are going to ask me a question. Yes, by and large, ultimate is the patient has seizure, all these things. Our level rise should not be more than 0.5. why I wrote this, in one of the literature they mentioned about 0.8 also. This is the one question which is asked to me by all the students after the class. Sir, should I go by this or you go by this? This is the single best answer. So always, whether acute or chronic, when you make hypertonic saline, it should be less than 0.5 or 0.5 to 1, and this absolute value carry no meaning. No meaning. Why? It depends on the body weight also. So many factors are there. So don't go by absolute amount. Just go by, increase the level by 0.5 to 1 milligram per liter per hour. Okay, I made your subject very easy. So friends, now treatment of SIADH. Summary is treatment of SIADH. Restrict fluid, restrict fluid, 3% saline, only if seizures, altered sensorium is there. That's all. Two things so far in acute cases. Now we move on to chronic SIADH. Patient has been hyponatremia for a long time. What to do? Long time. Has a patient is hyponatremia, you have a patient come to you today, he had done sodium today is 124, so one month back it was 122, but okay, no symptom. In such cases, do we give 3% saline? No way. Repeating 3% saline only in emergency. In these cases, we can give demeclocycline or conivaptan. So in chronic cases where patient has symptom of fatigue, malaise, then we can try with demeclocycline or conivaptan. These drugs, they are anti-ADH drug. They are anti-ADH drug. That means they will hamper the action of ADH and they will induce nephrogenic diabetes insipidus. And they will cause more and more urine to go out. They will counter the action of ADH. So point to be noted, we are using this drug in the treatment of SIADH, but they are the cause of nephrogenic diabetes insipidus. So these drugs, what we are using for the treatment of SIADH, are the cause of nephrogenic diabetes insipidus. So to complete the list what I gave you in the previous how to treat a case of SIADH in acute cases. So 3 words: restrict fluid, 3% saline, conivaptan or demeclocycline. So friends, treatment: restrict fluid, restrict, 3% saline, emergency, demeclocycline, conivaptan. Okay, in routine cases. That's all. Very simple. Okay, I hope things have been made to the simplest way. Okay, fluid restriction, 3% saline, emergency. For routine case, demeclo and conivaptan. Right, sir. So yeah, let me revise the entire SIADH only in 30 seconds. You have to answer the question. In SIADH, number 1, it come in which category? It come in the category of euvolumic hyponatremia. Number 1. Number 2, important causes that you don't have to forget: small cell lung cancer, hypothyroid, head injury, subarachnoid hemorrhage, and infection like pneumonias, and certain drug like a tricyclic antidepressant and vincristine. The clinical feature: no symptom, or fatigue malaise, or altered sensorium and seizures. Lab finding: what happened to serum sodium? Reduce. What happened to serum osmolality? Reduce. What happened to urine osmolality? Increase. What happened to urine sodium? Increase. Which is screening test, water loading test. What is the most accurate test? Serum ADH level. Treatment: what is the first line treatment? Restrict fluid. What you will give in emergency? 3% saline. What you will give in routine case, routine OPD case, fatigue malaise? Demeclocycline or conivaptan. That's all. This is the whole SIADH in the best simplified way. With this background, now we move on to pseudohyponatremia. There are certain conditions where the serum sodium is less, the plasma osmolality is high. You remember in the very early slide was, of course I discussed hyponatremia, hypovolemia. Okay, right? I discussed about hyponatremia with low sodium with low osmolality. At the same time, I told you there is one entity where the sodium is reduced but osmolality is increased. Okay, so this is so-called pseudohyponatremia. Pseudohyponatremia, this is seen in hyperlipidemia. Remember, criteria is what? Serum sodium reduced and plasma osmolality increase. Write down, I'm going to explain to you. Now, what are the causes we see in hyperlipidemia? Hyperproteinemia that we see in multiple myeloma, and hyperglycemia in like condition like DKA and non-ketotic hyperosmolar coma. In this, what you have to remember is number 1, number 2, number 3. Now let me explain to you how can the serum sodium will be low. Well, I have taken a blood sample of a normal person. Normal person, I take 100 ml of the, or maybe I take 1 ml of the blood sample. Yeah, and it has sodium of 140 milliequivalent. I calculate, fine. Okay, now I take 1 ml of the blood of a patient who has very high amount of lipid in the blood. Hyperlipidemia is there. When I keep this sample, blood is 0.5 ml. The lipid is 0.5 ml. Hyperlipidemia is there. Actual blood is 0.5 ml. But it has been mixed with 0.5 ml of lipid also. So, but when we so its sodium is, if I go by this, is 140 milliequivalent per liter. Okay, but here we are not taking blood sample, we are including including what? Lipid level also. So now we are calculating 1 ml, which is a blood plus lipid. So although sodium level is normal as per blood, but if you go by total, the volume goes down. So it's a technical problem. So friends, it means if you are getting hyponatremia, you will like to check the serum osmolality level also. The serum osmolality is normal, then we are dealing with pseudohyponatremia. Think about hyperlipidemia. Think about multiple myeloma and hyperglycemia. I will make it more simple. Any condition which lead to increased lipid, increased protein, increased glucose, hyperlipidemia, hyperproteinemia, and increased glucose, they are going to cause pseudohyponatremia. Agreed? Things made very simple. Sorry. Well, we have one more condition where patient has psychogenic polyuria. Very commonly asked question. But quite commonly seen in ladies, middle age, they keep on drinking water. They keep on drinking water, they keep on passing urine. Now you want to differentiate between the two. So if you are getting low serum sodium and low plasma osmolality, this we see in both. This we see in SIADH and this we see in psychogenic polyuria also. Okay, same finding. Then how to differentiate? Check urine osmolality. It's more than 100 in SIADH, it's less than 100 in psychogenic. So the question to you, what is the similarity between SIADH and psychogenic polyuria? Low serum sodium and low plasma osmolality. So how to differentiate? Check urine osmolality. Urine osmolality will be more than 100 in which condition? SIADH. Reduce in which condition? Psychogenic polyuria, polydipsia. Now I have one more beautiful question. A 62-year-old lady, lethargy, confusion, progress over last 3 days. Husband says lost 5 kg. She has a smoking history of 40 pack years of smoking, heavy smoking. Vitals normal, no orthostatic hypotension. No orthostatic, again one more beautiful line to know. Lovely, again not known to 99%, orthostatic. Orthostatic means postural hypotension. Postural hypotension means you check the BP in supine position. Patient is lying supine on the bed, you check the BP and then you make him stand for 2 to 3 minutes. Then after 3 minutes you check the BP. Suppose the BP was 130 by 90. This is supine position. Now you make him stand. Now BP becomes 104 by 70. So now 130 became 128. There is fall of 126. There is fall of 26 millimeter of mercury. If systolic fall is more than 20 millimeter of mercury, is a very strong indication of postural hypotension. This can occur in any condition where there is autonomic neuropathy. A and P stand for autonomic neuropathy like diabetes. But what is relevant to my talk? This other entity which is not known to 90% students is also seen in any condition which lead to dehydration or hypovolemia. Hypovolemia. Remember, the tongue was dry and now patient has come to you with dry tongue, with less amount of urine passing because of dehydration, And again, examiner says, "Fine, is it very serious? What clinical test you will do?" This question will be asked to you. You say, "Yes, sir." You check BP in supine and you check in standing position. If there is postal fall of more than 20 millimeter of systolic BP, and some of the books they write diastolic fall of less than 10 also. Anyway, 20 systolic is more important. By this you can say, sir, he is a case of severe low volume. Gold medal question is this, right? This is clinical test by which you can assess severity of dehydration, and of course tongue will be dry in this case. Anyway, there is no orthostatic, that means there is no hypovolemia, pakka. He is confused, tongue is moist, oh, he has clarified, there is no dehydration also. And there is no ankle edema. Now I think things are very clear. Sodium is less, potassium, urine osmolality 250, less than serum osmolality less than 250, it is less than 280, low. Urine osmolality high, checks X-ray reveal a right hilar scan, and this is the one. Remember, he's totally confused, and now we have already proven he's a case of SIADH. Concepts are clear, and treatment will be hypertonic saline, that we understood. Why? He is hyponatremia and confused. But what the reason? Why he has? Oh, he has a chest X-ray mass in the hilar region. What the cause? Small cell lung cancer. I told you, whenever you get chest X-ray, and the question can be asked this way also. Patient has cough, hemoptysis. The same thing he can ask. Cough hemoptysis can be asked that he is a case of lung cancer. So this question give you the cause, small cell lung cancer. Lab finding and clinical finding is confusion. Lab finding is low sodium, reduced serum osmolality and increased urine osmolality, and treatment is hypertonic saline. So this question gives you summary of everything. Repeating. So clinical finding, confusion. Lab finding, reduced plasma osmolality but increased urine osmolality. The clinical picture, confusion. The cause, small cell lung cancer, and treatment, hypertonic saline. Okay. One more question. Wilson, seizures, confusion, lethargy, losing weight, tongue moist, no edema. I think it's so simple. For you, it's a child's play. Lab parameters, sodium low, bicarb is in the normal range. And if you give rapid correction will lead to what? Osmotic demyelination. Do I need to explain this question? No way. By this only, hyponatremia, moist tongue, no edema, confusion, seizures, we have made diagnosis of what? The case of SIADH, and this we have to give saline, and you have to give, which if you give rapidly, it can lead to osmotic demyelination. This question, the previous question, is a summary of the whole SIADH. Okay, one more question. Again, you are getting increased urine osmolality, and now it's a neurosurgery case. Serum sodium has fallen from 118. Urine osmolality is high. Okay. And once you restrict the fluid, urine sodium is raised to 80 millimole. What is the most likely diagnosis? In this case, again, surgery is being done. Patient is, sodium is low. And I told you, in a head injury or a neurosurgery, whenever we are intervening, they can lead to SiADH. But why, sir, why I discuss this question? Already haven't discussed so many questions? No, it has a special meaning, not for SiADH. The coming question to you. Look into this question. Now I'll tell you why I asked that question, which was SiADH. We are getting 72-year lady. Again, surgical done. The previous question, surgery done for subdural hematoma, and burhole surgery was done. And sodium 116, 117, 115. Urine sodium is 25 and plasma osmolality. Oh, plasma osmolality 280. Yeah. And serum sodium less. One thing is very clear. This is not SiADH. Let's see. Dry tongue, which is again not seen in SiADH. This is cerebral salt wasting syndrome. This topic is not known to 95% students. They are not aware of this. So let's talk about cerebral salt wasting syndrome. What is this? Okay. So it is hyponatremia with dehydration. Hyponatremia with dehydration. Agreed. This is due to hypersecretion of ANP. Point to be noted that the entire SiADH problem was increased ADH, and that was retaining water. And that's why we were getting hyponatremia with normal volume. But the problem is ANP is atrial natriuretic factor. Atrial natriuretic peptide. It is main role, it lead to natriuresis. That means it causes loss of sodium and water lost in the urine. Got it? So it is going to cause sodium and water loss in the urine. It is seen in CNS condition like head injury, trauma, or any tumor or any neurosurgical operation done. Point to be noted, this same thing causes SiADH also. In this question also, patient had a SAH and patient was operated. In this patient has subdural hematoma, and any head trauma or head injury, etc. can also lead to SiADH. Same, but SiADH can occur in many other conditions, but this occur only in CNS condition. Now let us see. This is the form of hyponatremia due to excess renal sodium excretion. Write down, this is a gold medal line is there. Excess of sodium excretion in the urine, and this is centrally mediated process, not ADH mediated. Let me give you the example. I have a 1 glass of water, 100 ml of water is there and 100 milligram of salt is there. The concentration is 1 milligram per ml. Okay, 1 ml. Now in this glass what I do, I remove about 60 milligram of salt. I remove. How much water left? Now how much salt left? Salt in the glass. Salt in glass is now 40 milligram. Out of 100 I have removed 60, 40 mm. Now there is 100 ml of water. I remove 20 ml of water also I remove. How much water left? 80 ml water left in the glass. Water left is 80, sodium left is 40. The concentration of sodium goes to 0.5 milligram per ml. It is hyponatremia. But point to be noted in this, even water volume has gone down. From 100 it has gone to 80 ml. So there is hypovolemia and there is hyponatremia is there. And this is done in the body by A and P. It tend to lose more and more sodium, and it also tend to lose water, but amount of sodium loss is more than the water loss, and that lead to hyponatremia. Okay, understood? So it is a high. So summary is hyponatremia with dehydration and due to what? A and P. Symptom, they have polyuria. Why polyuria? As I told you, large amount of water going out with sodium also. Since sodium and water going out, he is dehydrated, he will have polyuria, polydipsia. Polydipsia, he like to drink more and more water. He is thirsty. He is thirsty. Okay, and his tongue will be dry. His tongue will be dry. Important point to differentiate from SIADI, tongue dry. And here intravascular volume is reduced. So it is going to have something. Now single keywords, salt craving. If you get salt craving, you are dealing with cerebral salt wasting syndrome. This gentleman is always want to take salt. I give you day-to-day example. One of your known to come to your house and you give him, he's your guest, you serve him with the nice cold drink and you serve him sweet, any sweet dish popular in your area. But he says, no, I don't want sweet. You give me salt. Salt? Yes. You are surprised. Normally nobody serves salt. Or, okay, he will ask you to keep his salt and he'll take salt, take. Or he may not ask salt, you have kept sweet, you have kept certain salty things also. You can notice he's only eating salty thing, he's not taking sweets at all. So if you are getting a person who is a craving for the salt craving, the usual question they ask, salt craving means, golden line to remember is cerebral salt wasting syndrome. He is losing salt and water. So he'll be always like to take salt. Maybe he may be taking directly salt. If you see somebody taking directly salt he keeps like this and take a water. From distance you can diagnose. Okay, you are, let's say you are sitting in a restaurant and you can nearby table. There is one gentleman who take the salt, keep like this, take water. From distance you can diagnose is a case of what? Cerebral salt wasting syndrome. Basic concepts are clear. And due to low intravascular volume, what we get? We'll be getting autonomic neuropathy in the form of postural hypotension. Do I need to explain to you? No way. I already made your fundas very clear. In these cases, you will get hypotension. Dehydration, yes, that's why it is having postural hypotension. So they want to have more and more salt and water intake, but I explained to you. Causes anything, brain injury and brain trauma, neurosurgery, anything with brain. No outside business, okay? And now again I talk about the same thing. It is to differentiate between SIADI because this also occur in the same scenario. Now I have a question for you. You are sitting right now watching my video, and because you are the physician, you get a call from a neurosurgical ICU, neurosurgical ICU. You get a phone call right now. Doctor, please come. There's one case who has been operated for a neurosurgical operation, and his sodium is 120. 120. Neurosurgery people are calling you now. They are very worried. They are very worried, 120, and they ask how to manage. How to manage? What is this? And how to manage? The question asked to you by the nurse from neurosurgery department. You are sitting, oh, you don't want to leave the lecture? How can you leave? Dr. Bhatia is teaching. They are calling you. Please come, please come. You say, oh, sorry, I can't come. I'm attending Dr. Bhatia's lecture. Then how to manage? Can you manage from here? Yes, you can manage. What you have to ask? You know, this can happen either via SIADH, or it can occur by cerebral salt wasting syndrome. This can happen. You should ask, yes, sister, tell me what is the patient tongue condition. Sister say it is wet, it is dry. It is wet means SIADH, it is dry means cerebral salt wasting syndrome. Understood? So in this case, so simple, she tell you, then BP normal, it is usually low. Why? Dehydration. What is BP? Doctor, it is 120 by 80. BP, it is 80 by 60. Okay, done. So what treatment you will advise? Now you have to tell me. What treatment you will advise? Treatment. Restrict fluid. Here you give excess of fluid. Excess of fluid you give. Maybe by patient has a cannula. Okay. Gastric cannula is there. Salt and water should be given. Salt and water. Salt water. Here you restrict water. Very simple. Very simple, you can give by this method only. All clear? Yeah. So the difference is that we are getting, and of course other parameter that we can talk about. Urine sodium is increased in both the condition, but in SIADH it is more than 100, but in case of cerebral salt wasting it is more than 150. And moreover, sodium level are, when we restrict the fluid, sodium level will increase. In SIADH it will, okay, that is the one thing. Restriction of fluid is the single most important in the treatment of SIADH. So lab parameters is one more thing. Urine sodium is more than 100. In SIADH more than 150 is the additional feature. But by and large, this is all additional feature you already have diagnosed by your best clinical examiner and best basic concept. Okay. So now a beautiful summary. This will make your fundas very, very clear. Difference between SIADH, again worth $1 million. Serum sodium reduce. It means this is common. That means hyponatremia is there in both the condition. Agreed. Urine sodium, it is increase. It is very, very increase. Highly increase. Urine output normal or slightly reduce. Here it is very, very, it is polyuria is there. Polyuria is there in cerebral salt wasting syndrome. Intravenous fluid status is normal or increase. Slight increase or normal, but it is definitely very, very reduced. This we can check by tongue. The same thing we can say by tongue examination. Tongue examination. So no need to say it will be normal, wet, it will be dry tongue. Simple. Neurosurgery sister asking to you in a hyponatremia, and you ask only one question, sister, tongue. Normal wet is SIADI, dry tongue is cerebral salt wasting syndrome. Only one line, worth $1 million. Serum uric acid level will be slightly reduced, maybe slightly increased because of hypervolemia. This is due to dehydration. They're all due to relative fluid loss or low. ADH level is increased in these cases. In these cases, usually ADH level may be normal or slightly reduced because nothing to do with it is due to ANP, not due to ADH. Treatment restrict water. It is water. You give salt and water intake. Treatment. So now is lovely summary. Lovely summary is there. Lovely summary is there to tell you all the difference between the two. So you are clear about cerebral salt wasting syndrome also. We got another patient, Mr. 70-year-old male, type 2 diabetic patient, and he's less interactive, he's confused, BP is low, orthostatic hypotension is there. Oh, dry oral mucosa, fine. Are we dealing with cerebral salt wasting syndrome? Let's see. Aha, 166 sodium. This cannot be cerebral salt wasting syndrome. So in cerebral salt wasting, till now it looked to me that we are dealing with cerebral salt wasting. Orthostatic, low BP, dry mucosa, but this changed my concept. We are dealing with hyponatremia. Oh, there's something more confusing. Let's discuss. And potassium is normal. Which is the best hypotonic fluid you like to give? Well, this is 0.9%. This question is done wrong by almost 90% people commit mistake on this question. And the distracting word is hypotonic fluid. And I'm sure the moment I say 0.9, many of you are going to ask me, sir, how can this is a normal saline and you are asking for hypotonic? Yes, that is a gold medal question. And this you will never understand unless we know the basic concept about osmolality. Now in this question, sodium is 166, potassium is 4, glucose is 900 milligram, and which is so-called 50 millimole per liter. If you go by millimole, BUN is 14 milligram percent, it is 5 millimole per liter. Now I give you 60 seconds to think and answer. Calculate the plasma osmolality of this patient, and your time starts now. Write down in your copy, calculate the plasma osmolality in this patient. Those of you who will be seeing later on as a recorded lecture, then they can stop the video here, calculate, then they can start the video again. But those at the moment they are seeing live, I give you 60 seconds to think and answer. So let's start. How to calculate plasma osmolality? Formula is sodium plus potassium multiplied by 2 glucose and BUN, and they are taken in millimole per liter, not in milligram. So 166 is the sodium, 4 is the potassium multiplied by 2 plus glucose in millimole is 50. BUN is 5 in millimole per liter. This comes out to 170 multiplied by 2 plus 55. This comes out to be 340 plus 55. So this comes out to be 395. So in this case, the plasma osmolality is 395. Normal is 280 to 300. So this is a case of hypernatremia. So hypernatremia, right? Well, again we go back to the condition. He has got hypernatremia, which could be due to, of course, glucose level is very, very high, and this could be due to high glucose level. And this we see classically in non-ketotic hyperosmolar coma, hyperosmolar coma. Non-ketotic hyperosmolar coma. Sir, can it be due to diabetes, ketoacidosis? There also sugar is high, but here the bicarb is 29. It's normal or slightly on the alkaline side. This is not a acid, because if it was a DKA, the bicarb should have been less than 20. This is not DKA, we rule out. Agreed? So one thing DKA, so this is more likely to case of non-ketotic hyperosmolar coma. Now here the sugar value is 900. Suppose same, every parameter same, and if it is 90, if sugar is 90 milligram percent, or you can say sugar is 5 millimole per liter, sodium remains the same, then what could have been the diagnosis? Then the answer would have been adipsic hypernatremia. So now I'll be discussing two things. Of course, the common factor is hypernatremia. What is this? I'm going to discuss. But first, now let me tell you how to manage this case. In this case, plasma osmolality is very, very high, 395. I have to give a hypotonic fluid. I give normal saline. It is isotonic when the plasma osmolality is between the range of 280 to 300. This is isotonic. But when it is 395, it becomes hypotonic to this. Got it? So we keep on giving normal saline, of course with insulin also, no need to say, sugar high. So initially we give normal saline. I will just talk about saline, not about insulin. So I give saline, and now the plasma osmolality 395 we calculate. Once it comes to 320, then I switch over to N/2 saline. And when it comes to 300 in the upper level of normal, I may even switch over to oral water. If the patient is conscious, by the time patient becomes all right, he can take water, I'll switch over to oral water, or I may even switch over to maybe 5% dextrose, of course with insulin. I have to keep a watch on sugar. So friends, starting with normal saline, and by 2 saline, and finally pure water is the management in this case. Understood? So now you understood that even 0.9%, which is a so-called isotonic saline, can be hypotonic depending on the plasma osmolality. With this, I talk to the other, again one topic, adipsic hyponatremia, which is again not known to most of students, but don't worry, I'll make it very, very simple. So now second is adipsic hyponatremia. Write down. Heading of discussion is adipsic hyponatremia. Well, I give you a day-to-day example. You go to your friend's house. It's a summer month, 45 degrees the temperature. You are totally thirsty. You go to your friend's house and he serves you maybe a glass of Coke, Pepsi. What you say? No. First give me water. First give me water. Why? Summer month, you are lost lot of water from the sweating. You are dehydrated. Your plasma osmolality has gone to T310, more than 300. And with this, your thirst center in the brain is activated. Thirsty. Oh, drink water. Thirst center activated. Well, your friends serve you a glass of water. You take a glass of water. You take. Immediately you drink it. And you are taking pure water. Pure water will be absorbed immediately. Water get absorbed in stomach only. Okay? Water get absorbed in stomach. Yeah. One more question. Write down the answer. Water get absorbed in stomach, and majority of the food what we take is digested and absorbed in intestine. But there are only 3 substances which are absorbed in stomach. One is water. Tell me other 2 items, food items, which are absorbed in stomach. Write down the answer in your copy. Quickly, which food element are absorbed in water, in stomach? Well, I'm sure you have written the answer. Answer is glucose. Pure glucose, not starch. And second is alcohol. Alcohol also get absorbed in stomach. That's why if the person takes the alcohol very fast, it get absorbed in stomach and the patient get intoxicated very fast. And शायर लोग कहते हैं, शायर लोग गाना गाते हैं, पीते ही नशा आ गया. You are sitting in a mushaira, शायर is sitting, पीते ही नशा आ गया. You stand up and say, because it is the alcohol get absorbed in stomach only. So he made a statement and you get the scientific reason. Okay, anyway, it was just to make you light. Those of you who could not understand Hindi, well, I said somebody sings a song that I got intoxicated after taking alcohol. Then you stand up and say, oh, because alcohol got absorbed in stomach only. Yeah, we come back. So this is the normal physiology, and once you are taking water, you are thirsty, your plasma osmolality, which was 310, it has come to 290. Oh, you are very happy. It has come normal range. But suppose there is one patient, again head injury patient. He had a head injury in the back sometime, maybe 2, 3, 4 months back, and now his thirst center is gone. His thirst center is damaged. Now his osmolality go to 310. Now he doesn't feel thirsty. Why? That center is not working. So he will be totally dehydrated. This is so-called adipsic hyponatremia. Although the sodium level has gone high, but he is not feeling thirsty. Adipsic, no thirsty, because the center is damaged by head injury. So now look, head injury causes SIADH, head injury causes cerebral salt wasting syndrome. The head injury can lead to adipsic hyponatremia. So we learned about so-called adipsic hyponatremia, right? So let's learn more about it. Let's learn more about adipsic hyponatremia. Yeah. In this, there is a chronic or recurrent hypertonic dehydration. Hypertonic, why? The serum osmolality has gone high, and his dehydration, the way I explained to you. And there will be hyponatremia, will be sign of hypovolemia. Yes, he is thirsty. Hypovolemia is there, but hyponatremia. Point to be noted: cerebral salt wasting syndrome. There was hypovolemia, but there was hyponatremia. Here we have hypovolemia and hyponatremia. Due to hypovolemia, there will be feature of postural hypotension. Understood? Muscle weakness, pains, etc. can occur in these patients. How to treat this case? Here you have to give only water. Treatment is only water. Patient already has very high amount. So again we give example. I have a glass. Here salt is 150 milligram. Water is 100 ml. And I want it should be 1 milligram per ml. What will you add? Only you have to add 50, you have to add only water. You have to add only 50 ml of water. You add it. Once you add 150 ml water, it becomes 150 ml, and the concentration goes to 1 milligram. So treatment is only water intake. If the patient is alert, otherwise you give 5% dextrose. That's all. 5% is given, right? But one more thing, same. Initially if the patient has got severe hypertonia, if the serum sodium is, suppose the osmolality is very, very high, we may even give 0.9% saline, but later on N/2 or pure water. Otherwise, if they don't talk about saline, you can simply say only want to give water. Only water is the answer in this condition. Okay, right, sir? So what are the key word here? Hyponatremia, decrease intravascular volume, tongue dry. Tongue is dry. Treatment is pure water. That's all. Very simple. But pure water is the simplest thing I can say, but we can try 0.9% if the osmolality is very high. This is summary of adipsic hyponatremia. So this is the adipsic hyponatremia in cerebral salt wasting syndrome. Cerebral salt wasting syndrome, there is hyponatremia, reduced intravascular volume, and in case of SIADH, there is hyponatremia and intravascular volume is normal. So beautiful summary of the three things. Treatment is pure water, water and salt, restrict water. Friends, this is the summary of the entire sodium disorder. Squeeze in. If you want, I can write a better one. This is cerebral salt wasting syndrome. This is the SIADH, adiposic hyponatremia, serum sodium reduce high. Okay, serum sodium is reduced. Second is volume status. Volume status. Fluid volume status. It is reduced. It is normal or slightly increased. It is reduced. Treatment: salt plus water. Restrict water. Give water. Give only water. Friends, this is the summary of what I taught so far. This is summary. This summary of what I have taught in the last more than 2 hours. Very simple. And not to forget, all the three can occur in head injury. So now you will not, I hope you are master of this subject. But still, anybody has any doubt to ask me, you are very well free to ask me. I'll give you my email ID at the end. And and we also have many recorded lecture also for other topic also. If you want to see, you can very well mail us or WhatsApp at the end of the lecture, but I'm going to show you. Okay, so I hope you are very clear about sodium concept. Summary. This is a summary of whole show. Potassium disorders, very commonly asked question throughout the world. There are certain two basic questions. This is very essential to know. What percentage of total sodium is in the extracellular fluid? Very basic, is 2%. Sodium is primarily extracellular. Potassium is primarily intracellular. Let's read more about basic concept about potassium. Friends, total amount of potassium in the body is about 50 milliequivalent per kg. Total body. That means the person has got a weight of 50 kg. Now you can calculate 50 kg. The potassium will be somewhere around 2.500 milliequivalent. Now out of these 50, 90% is intracellular. I mentioned you, potassium is mainly intracellular. 8% in the skin and the bones also, that is consumed. And only 2% is extracellular. So, for us, for electrolyte imbalance, it is this element which is important, which is going to determine hypo or hyperkalemia, although very little amount. Okay, and this little amount is to be maintained in the normal range when we talk about normokalemia. So the key word to remember is only one, is 2% is the only key word that you got to remember in this particular slide. Now one more question, again a basic question. We call a severe hyperkalemia when the potassium level is more than 7 milliequivalent per liter. Let's read more about this. Normal potassium level is between 3.5 to 5. Okay, More than 5 will be hyperkalemia. Definitely it is higher than the normal will be hyperkalemia. 5.1 to 6 is mild hyperkalemia. Mild. If it is 6.1 to 7 is moderate, more than 7 is severe. And same thing I mentioned in the previous slide also, severe hyperkalemia means more than 7. Inside the cell is 135 milliequivalent per liter. Point to be noted is a very, very high level inside. So out of this is important to remember. This is important to remember, and it is important to remember about this. Of course, if you remember other also, there is no harm. With this background, I'll be using two terms. One is chronic hypo or hyperkalemia, okay, or one is acute hypo or hyperkalemia. When we say acute hypo, they occur in hours or days. But if I say chronic hypo or hyperkalemia, that is there for weeks to months. They are important to understand. They have a lot of meaning. I'll be discussing little later on. And one more thing. What I told you, 3.5 to 5 is the normal range. Now you are the treating physician. When you should be alert? Well, if the patient has 3.2, do I need to be very alert? No. The patient has 5.5, do you need to be very alert? No. But we have to be watchful. But your eyes should open if you get a report. Potassium is less than 3 or more than 6. That is the one which should be really, really alarm you in why this is so. Then you have to be very aggressive in investigating and treatment. There are simple important point to tell you the importance of acute chronic, and number 2, importance of hyper to less than 3 and more than 6. With this background, now we come to the question. We are getting John, 65-year-old male who come with fatigue. He has a chronic liver disease, kidney disease. His vitals are normal. Moist tongue is there. Potassium is 6.1. BUN 38. Creatine 2.4 milligram %. Glucose level is slightly on the higher side. Okay. And 2 months ago his creatine was 2.5 or 2.4. Now the creatine is again 2.4. That means not much change in kidney function. With a simple one line, he has very clearly ruled out that there is no problem in the kidney as such. Normal sinus rhythm. Normal sinus rhythm means, remember, potassium disturbance lead to arrhythmias. So normal sinus rhythm he has ruled out, although hyperkalemia is there. How do you say it? 6.1. But as such, there is no arrhythmia, that means there is no cardiac toxicity as such. This line has a special meaning which I will be discussing later on. Now what is the one thing you like to do? Okay, calcium gluconate, no. Renin, no. These, no. Why no? I will be discussing in the coming slides. But as of now, hyperkalemia has occurred. It is slightly on the 6.5 is not higher side, but not extreme high. But remember, there is no problem. You review your current medication, the answer. He has got so many diseases. He has got diabetes, hypertension, hyperlipidemia, chronic liver disease. He has n number of diseases are there. Let us investigate what he is taking. Okay, right? So there are certain drugs which can lead to hyperkalemia. If you go for the causes of hyperkalemia, there are n number of causes are there, but let's see what drugs. ACEI and ARB. The patient is very, very important. Potassium sparing diuretic like spironolactone or amiloride. Even, okay, they're all potassium, they retain potassium. non-selective beta blocker, NSAID, digoxin, and succinylurea. Well, they are the important drugs, but otherwise, which can lead to hyperkalemia. In addition to that, heparin, cyclosporin, they are the important drugs which can lead to hyperkalemia. But if you open the book, there are n number of drugs are there. But out of these, if don't forget number one, don't forget spironolactone, heparin, cyclosporin, and succinylcholine. And of course digoxin. Don't forget this. Very, very important drug which can lead to hyperkalemia. So we like to, in this patient, we like to go for, let's see if already he had been given new drugs, he has edema of feet, and any drug which is causing hyperkalemia, quite possible he is taking ACI, quite possible he is taking potassium sparing diuretic, review. But what about others? Why they are not? Because they have a special indication. In a nutshell, what I say, he has no problem because his potassium is high, but his cardiology, arrhythmias, ECG is normal, so we have to just review the drug. Now, when to give specific treatment, that I am going to discuss in the coming lectures. Let's look into this question. We get a 66-year-old male for follow-up appointment, routine appointment. He being taken, stable angina and long-standing hypertension is there. Examination is normal. Sodium is 138, normal. Potassium 5.6, slightly on the higher side. Calcium is normal, bicarb normal, creatinine normal. And if you add with lisinopril, which can do this? Amiloride. What he is asking, that we learned in the previous question, the lisinopril lead to hyperkalemia. Now, which other drug if we add, we're going to call hyperkalemia. So if you look into the causes of hyperkalemia, amiloride was the one. These drugs, these are diuretic, they both cause hypokalemia. These drugs, they don't cause any potassium disturbance by and large. Anyway, this is the best drug. So we understood if that means in a patient taking ACI, if you want to add diuretic, then if you plan to add potassium sparing diuretic like this or spironolactone, you have to be very, very careful in adding the potassium level. You have to check potassium. But what about these drugs? These drugs you can give very comfortably because lisinopril is going to increase potassium level and they are going to reduce potassium level. So we can comfortably combine this drug. Okay. Now come the main question is this. Okay. Lovely question. Again, good question. We get a quadriplegic man. He started on intravenous antibiotic and he has got progressive failure and he is to be given skeletal muscle relaxant because if you have to intubate, you want to put the patient on ventilator, you have to intubate and you have to give any muscle relaxant. Okay, and you give, he got ventricular fibrillation and potassium is 10. Oh, very, very high. Extremely high. It's so high, it has led to ventricular fibrillation. And it happened soon after giving a muscle relaxant, that is succinylcholine. You remember in this list of drugs which can lead to hyperkalemia is succinylcholine. It is such an important point. Whenever an anesthetist is there, they want to intubate. One thing every anesthetic will want is serum potassium level. He will like to know, especially when he is planning to give succinylcholine. It can lead to sudden increase in potassium level, and that can create a lot of problem. Now I have a question for all of you. Write down the answer. You are giving succinylcholine to a patient. Some patient can have problem regarding body temperature also. Write down the answer. What can happen? Temperature may become low. It may go very, very low. It may high, or it may go very, very high. I give you 20 seconds to think and answer. Those who will be seeing the video later on, they can stop the video to write the answer. Write down the answer. Temperature goes low, very low, high, or very high. The answer is it can lead to very high. The one more complication but they can have is malignant hyperthermia. The malignant hyperthermia is a problem that can be seen in patients who have been given succinylcholine, okay, severe hyperkalemia, especially in burns patient or myopathies. Remember, our patient has a quadriplegia, muscle are weak, and of course they can lead to bradycardia or tachycardia both. But as of now, that we are concerned in a patient who is quadriplegic, he has to be intubated, we give succinylcholine, and that led to hyperkalemia, and that led to ventricular fibrillation. In fact, I included this question to talk to you that severe sudden hyperkalemia can lead to ventricular fibrillation. Is nothing but like a cardiac arrest. It has a lot of meaning for my next question to come up. So now regarding metabolic hyperkalemia causes, you should never forget the metabolic acidosis, Gordon syndrome, RTA type 4. RTA stands for renal tubular acidosis type 4. Drug like ACI cyclosporin and Addison disease. This you don't have to forget. Otherwise, huge list is there. But don't forget this. Metabolic acidosis, Gordon syndrome, RTA drugs, and Addison's disease. Okay. Now let's talk about what are the clinical features when the patient has got hyperkalemia, muscle weakness. Okay. And this is due to altering transmembrane electrical potential. Okay. Muscle weakness, flaccid paralysis, and hypoventilation. Why? Muscle are paralyzed, including diaphragm. Including diaphragm, so muscle are weak, so that means a type of flaccid paralysis occur, right? Cardiac toxicity, it can lead to so this was regarding muscles. It can lead to palpitation, it can do arrhythmias. One golden line to remember that whenever we have potassium toxicity, either hypo or hypo, it lead to arrhythmia. It can lead to sudden death. Hyperkalemia can stop VF and asystole. Point to be noted, for this line only I added this question. Patient can have cardiac arrest in hyperkalemia, in ventricular fibrillation, or asystole. Either can be there. In our case, in the question we gave succinylcholine, hyperkalemia, it went into ventricular fibrillation is there. Understood? So this what is going to have. So in nutshell, so if I have to give you summary, is hyperkalemia. The clinical feature, 2 words, is muscle weakness and arrhythmias. This is a summary of the entire hyperkalemia in 2 words only, muscle weak or arrhythmia. Now let us see what happened in the ECG finding. In the ECG finding, let me show you ECG finding. This again is very, very important. This is a normal recording. Normal, this is T wave. Normal recording. When the hyperkalemia occurs, the first thing is tall T wave. Tall T wave. The first thing to happen. Later on, prolonged PR interval. This is the PR interval. Prolonged PR interval. Tall T wave remain. This is the prolonged PR. Arrow upward means prolonged. Is the second finding you get it. Still later on, P wave disappear. And this is known as atrial arrest. Atrial arrest. Now I give you again 10 seconds to think and answer. Why we call as atrial arrest? Write down the answer in your copy quickly. Why we call it to be atrial arrest? Any specific reason? Well, the answer is P wave is produced due to atrial contraction. And since atria is not contracting, so no P wave, so we call the word as atrial arrest. And finally, you get wide QRS. Wide QRS, so-called sine wave. So-called sine wave. Okay. So sequence is tall T wave, prolonged PR, atrial arrest or P disappear, or the sine wave is wide QRS is sine wave. Sine wave. Okay. With this background, we come back, and ultimately sine wave goes into ventricular fibrillation. So this was just to inform you, low P wave, prolonged PR interval, and peak T wave is just a simple example to show you. This you can see, same thing, P wave are disappear and we are getting a very tall T waves. Very tall T wave, no P wave is the finding that you are getting in this patient. Lovely ECG. Let's talk about question number 6. 64-year-old, confused, lethargic, chronic renal failure, temperature 99.2, left-sided weakness is there and facial drops are noted. Potassium level is very high, 7.4, and he has a muscle weakness also. Okay, bicarb is 17, glucose is, and wide QRS with bradycardia. One more finding that in case of severe hyperkalemia, even bradycardia also occurs. Additional finding you can write down in the ECG that bradycardia also is the feature of severe hyperkalemia. So this picture is going in favor of hyperkalemia. Definitely this is one which gives a diagnosis. Now how to manage this case? Well, the first thing is injection calcium gluconate. And now we will correlate this treatment with the previous question where we have reviewed the drugs. Patient had no symptom, but here patient has the problem of ECG problem is there. So we can't be very lightly, and potassium level is very high, severe hyperkalemia. So first of all, acute hyperkalemia, we give injection calcium gluconate. What is the idea? Let's learn the basic concept. First of all, we want to minimize the membrane depolarization. And second, we want the potassium level should go down. So first drug is calcium gluconate. It stabilizes cardiac membrane and it decreases excitability. How come? And why? Why high potassium can lead to arrhythmia so fast? Let's learn this thing. Look into this. Now let's correlate with physiology. In cardiac physiology, all of us know that we have a threshold potential. Okay, and threshold potential there, once the action potential reaches threshold potential, firing start. When hyperkalemia is there, this threshold potential rises here. It quite near to the resting membrane potential. Resting membrane potential become quite near to threshold potential. So that's why it can lead to firing very fast. But once we give calcium gluconate, this resting membrane potential is put downward. So increased gap is there, so it reduces excitability. So which the first drug to be given? Calcium gluconate. What does it do? It reduces the resting membrane potential. What is the net result? It reduces excitability. But point to be noted, it has not reduced the potassium level. It is still as it is. Now I give example. Suppose you are sitting somewhere and there is some short circuiting occurs. The fire starts. You have two options. One is to switch off the mains. You simply go and switch off the mains. Or second option is you call the fire brigade. What you will do? Definitely switch off the mains. Why? Once you switch off the main, it will spread, it will stop the further spread of the fire. Fire brigade, this will be done immediately in 1 second only. But fire brigade will take some time to come. Fire brigade cannot reach in 1 second. So that's why exactly same reason we give calcium gluconate. We stabilize the cardiac membrane, it prevents arrhythmias. Understood? Yeah, we understood the basic concept. Now we want to do something so that the potassium level is reduced. For that, what we do? What we do is, just a minute, my system has hanged. Just a minute, wait. Just wait. I call my staff to do the technical problem. Just wait. Okay. Let us start. Sorry for the inconvenience. So we gave injection calcium gluconate and it stabilizes cardiac membrane. And now we have to do something which can reduce potassium level. So how to reduce? We give dextrose glucose with insulin infusion. It's the fastest, earliest and the best way to reduce potassium level. What is the basic mechanism? This is the cell and we have given glucose with insulin. Due to insulin, glucose will enter into the cell. And we also know that when glucose enters the cell, it takes potassium as a co-transport. So this way we can reduce the potassium level. So in actual practice, this of course calcium gluconate given first and after that we give dextrose insulin drip. Other thing that we can give is beta 2 agonist like albuterol or salbutamol. They are the beta 2 agonists. They cause entry of potassium into the cell, right? And due to, and of course, if they are used excessively as a side effect, they can lead to hypokalemia. And when the hypokalemia occurs, then patients start having tremors. This is the main side effect. Why? This is a basic mechanism why tremor occurs by these drugs. There's no role of soda-bicarb in the treatment of hyperkalemia. Soda-bicarb is used only to treat severe acidosis, but it's never used in the treatment of hyperkalemia. Okay. Now, treatment of chronic hyperkalemia. Removal the sore potassium can be, now we want to remove potassium from body, we can use diuretics like furosemide. We can even go for dialysis also. If the patient is a chronic renal failure, it's automatically removed. We can use cation exchange resins like calaxate. It is remove potassium from the body by chelation. It is given oral. Rather, it chelates iron, potassium which is going with the food. It chelates the potassium at the level of GIT. Contraindication include ileus, bowel obstruction or ischemic gut. So in any problem of GIT, definitely the problem is GIT, ileus or any major problem, don't give. But it is an orally acting drug. We especially use in condition like chronic renal failure, where we with the CRF, because due to CRF potassium level is very high, mainly used in such conditions. So a quick recap, how to treat a case of hyperkalemia. Acute treatment, number 1, injection calcium gluconate. Number 2, dextrose insulin drip. Number 3 is beta 2 agonist. 3 words. Calcium gluconate, dextrose insulin drip and beta 2 agonist. Chronic, again 3 words. Diuretic, dialysis and resins. That's all. 3 and 3. You can answer any question on hyperkalemia. So in the previous question, most rapid way is dextrose insulin drip. I hope things are clear to you. No need to discuss. Same thing, which has got no role to play, is soda bicarb has no role in the treatment of hyperkalemia as such. It has a role in the treatment of only acidosis. Which of the following is the cause of hypokalemia? Answer is B12 deficiency. Okay, B12 therapy, not deficiency, sorry, it is therapy. Okay, this is a lovely question. Rest all they lead to hyperkalemia. Okay, rest all lead to hyperkalemia. Now I like to discuss this. If you read Harrison, 20th edition, page number 305, that is like this. And we know Harrison has got 2 columns. Here in that upper part, the table is there. Causes of hypokalemia is there. In that list, they say one of the causes is B12 and folic acid therapy. But if you read description, there's nothing is given. This is 20. You read 15th edition. Same table is there. But in the description, what they write, that if you treat a case of B12 megaloblastic anemia with B12 and folic acid, this lead to hypokalemia. And the reason being that because when we give B12 to a patient of pernicious anemia, it lead to increased RBC formation. and that lead to hypokalemia. That's all. Nothing else is given. But if you read 11th edition of Harrison, same table is there. And if you read description, what he writes, say when we give B12, it leads to increase RBC formation. Then he adds one more line, but why this does not happen in other deficiency like iron deficiency anemia? In iron deficiency anemia, you give iron, there also increase RBC formation occur. But hypokalemia doesn't happen. Reason not known. This is given in 11th and 12th edition Harrison. Anyway, this is very so. What is the simple question to ask? But what is the treatment? What question they will ask you? You have got one patient of B12 therapy, pernicious anemia. You are treating with B12. What electrolyte imbalance can happen? Answer is hypokalemia. So let's talk about more. We know that normal level is 3.5 to 5. Less than 3, between 3 to 3.5, we call as mild. Then 2.5 to 3 is moderate. Below 2.5 is severe hypokalemia. The way we have a category of mild, moderate and severe hyperkalemia, we also have for hypokalemia. Less than 2.5 is severe hypokalemia. Cause of hypokalemia, decrease intake or redistribution, any cause of metabolic alkalosis. Remember, whenever we have acidosis, H ion goes in, potassium comes out. That's why in acidosis, hyperkalemia occurs. In alkalosis, reverse happen. In alkalosis, reverse happen means H ion comes out and potassium goes in. So alkalosis, hypokalemia occurs. In alkalosis, hypokalemia occurs. Okay. Just a minute. System has hanged again. Yeah. Sorry. Friends, we got hypokalemia, alkalosis, hyperkalemia, acidosis. Now come the gold medal question. Write down the answer. Tell me any condition you know of where there is metabolic acidosis with hypokalemia. Write down. Those who will be seeing the later, you can stop the video, but for the current students, I give you 20 seconds to think and ask. Cause of metabolic acidosis with hypokalemia. Well, the answer is severe gastroenteritis, especially diarrhea, severe diarrhea. Then we have Bartter syndrome. This is renal tubular acidosis, type 1 and type 2. There are the three causes: diarrhea, renal tubular acidosis, type 1 and type 2. There are three exceptions where patient has metabolic acidosis with hypokalemia. This is a gold medal getting questions there. Then I talked to you regarding B12 therapy, and hypokalemic periodic paralysis is again a cause of. This is a genetic condition which is an autosomal dominant condition which can lead to hypokalemia. It is dominant conditions there. There can be increased loss, renal loss, diuretic or non-renal loss in diarrhea. They all can lead to hypokalemia. This can happen in condition like hyperaldosteronism, typically Cone syndrome. It may occur in Cushing syndrome, Bartter and Gentleman syndrome. This list is there. This is given in all the books. So even if you could not write, don't worry, this is given in all the books. Okay, however, if you can write, fine, but not, don't worry at all. Right. Now come the RTA type 1, type 2, I just mentioned to you. Amphotericin B, don't forget this drug. 90% chances in your question when they talk about hypokalemia drug, they will not ask you furosemide, thiazide. Everybody knows they lead to hypokalemia. But this is the one thing you should not forget. Very, very important question, very frequently asked. Liddle syndrome, I have discussed the one test. In test number 1, I discussed this point also. Right, so if those want to see more detail, they can see my test on test and discussion, test number 1. It is there in YouTube also. This is the gold medal question. Hypomagnesemia can lead to hypokalemia. And this is so-called potassium resistant hypokalemia. Something unique. 99% students have never heard like this. There's something called patient has hypokalemia. You keep on giving potassium. Patient doesn't respond. Investigate for magnesium level. Potassium resistant hypokalemia is in hypomagnesemia. The clinical features: muscle weakness. Point to be noted, same happened in hyperkalemia also. Hypoventilation, same thing happened in hyperkalemia, muscle weakness. But one more thing which is often seen is paralytic ileus. It is the weakness of the intestinal muscle. This is more seen in hypokalemia. But as polyuria is additional finding that we get in these patients. Why? Let's learn the basic concept. Here is the nephron, and we know that ADH act at the level of collecting tubule, and when hypokalemia is there, then ADH is not able to act. It becomes ineffective. So ADH is not able to act at the collecting tubule, so water will go out. And this is so-called nephrogenic diabetes insipidus. Common cause are hypokalemia, hypercalcemia, lithium therapy. They all lead to nephrogenic diabetes insipidus. So now you get polyuria. Arrhythmias. Arrhythmias are very common in these patients. Why? Because remember, in the very beginning I told you potassium has, whether high or low, they have a cardiac toxicity. And one more thing, not known to 99%, severe hypokalemia can induce impaired insulin release. Can be there in some cases, if not all. But this is a very, very important point. So let's learn what are the ECG finding. ECG finding, this normal finding, T wave. When the hypokalemia start occurring, T becomes shorter and a prominent U wave appear. T becomes short, prominent U wave appears. In the advanced stages, tall P wave, prolonged PR interval, then T may disappear or may become flat, or sometimes it may become inverted also. May become flat or inverted. U wave appears and a prolonged QT interval. This is the prolonged QT interval. Prolonged QT interval. Now somebody is going to ask me, sir, there is no T wave, then how can you talk about QT interval? Yes, you are right. In fact, it is QU interval. But traditionally it has been called as QT, and rather some of the textbook they write as pseudo QT interval. Pseudo QT interval prolonged. Because this not T is QU, either way they can write, but traditionally we say prolonged QT. Out of these you forget everything, I don't mind, but prolonged QT, this is a single word, single most important word that you should never forget. Why? Because this prolonged QT interval, which can predispose to arrhythmia, so-called torsade de pointes. Torsade de pointes is the answer. So this is all about hypokalemia. So whenever we are treating, okay, so this is the ECG finding, slightly peak P wave, prolonged PR, HT depression, shallow T wave, prominent U wave. It's a simple word just to explain to you. Now we got a patient, male patient on an amphotericin therapy due to histoplasmosis. ECG revealed frequent premature beats, drug toxicity. This is renal tubular dysfunction. Yeah. Amphotericin is the notorious to cause nephrotoxicity. It decreases the GFR and a direct toxic effect on the tubular epithelium, and by this it causes loss of potassium, and that lead to hypokalemia. But one thing you got to remember, amphotericin hypokalemia is the golden line you got to remember, or other way around, amphotericin lead to nephrotoxicity is the one you got to remember. Okay. One thing, not only it lead to hypokalemia, it also lead to hypomagnesemia also. Oh, very smart. And we read just now, hypomagnesemia will lead to what? Potassium resistant hypokalemia. It means whenever you are treating a case with magnesia, with the amphotericin, not only you have to keep a check on potassium, also magnesium. But if you don't check magnesium, you keep on giving potassium, patient will not respond. Golden line to remember. And hypokalemia can lead to weakness and arrhythmia. That's why we are getting premature beat in this particular question. And we got one more question. 50-year-old man, emergency room, worsening dyspnea for the last 4 days, purulent cough, sputum. He's a case of chronic bronchitis. His temperature is 99. His pulse is tachycardia is there, oxygen saturation is 83% low, wheezing, and nebulized albuterol is being given. Okay. Potassium level is reduced. Right. So what's the reason why he's having? The answer is increased beta energetic action. In the causes, I told you one thing, that beta energy, anything which causes increased activity of beta energy, it shifts the potassium inside. It causes hypokalemia. So he is asking about which drug can lead to, or which activity can lead to hypokalemia. And I mentioned that in hyperkalemia, if you give albuterol, which is a beta-2 agonist, and that causes entry of potassium into the cell. So same thing, if used overnight, overdose, it can lead to hypokalemia. The point I mentioned to you when I discussed, the same thing has been asked in a different way, is a side effect of hypokalemia, is a side effect of albuterol. Now, whenever we are, how to approach a case of hypokalemia? Hypokalemia, whenever we are getting hypokalemia, check blood pressure. It is high, then there may be increased mineralocorticoid activity. If BP is normal, then it is either GIT loss or maybe renal loss. BP is normal, most likely it is GIT or potassium loss. How to check it? Check urine potassium. If it is due to GIT cause, then it will be less than, urine will be less than 20 milliequivalent per liter. But if it is more than 30 milliequivalent per liter, this is a renal loss. So friends, normal BP, potassium low, check for the urine potassium. Less than 20 is GIT loss, more than 30 is kidney loss. And now one more thing, you can even check urine chloride also. Urine chloride, it is loss is more, increased urine chloride in cone or Bartter syndrome, and chloride is reduced in GIT loss. So in case of GIT loss, urine potassium and chloride are both lost, both are reduced. So in GIT loss, urine potassium and chloride are decreased. In the renal causes, they are usually potassium and chloride both are increased. Finally, we get a question. We are getting amphotericin patient, hypokalemia. You want to give. Whenever we get potassium, we always prefer to give oral supplement. But here, it's a 2.3, it is severe hypokalemia. We know the definition. 3 to 3.5 is mild, 2.5 to 3 is moderate, less than 2.5 is severe. It has severe. So we always give by infusion. But what is single most? We give very slow infusion. It should be given very slow, maybe 10 to 20 millimole per hour to be given very slowly, so that potassium level again rises only 0.5 milliequivalent per hour. It should be given very slowly. Very slowly, less than very slowly. Never give rapid. If you give rapid, it will develop arrhythmias. Very, very slow infusion should be given. So here the best answer is 20. Even if 10 was the option, then 10 would have been the best answer. Invariably, they ask very slow infusion. Okay. So treatment is oral supplement, and you give very slow infusion to be given. 10 to 20 millimole per liter per hour is the flow rate that you should give very slowly. Well friends, I hope you liked the lecture. I have got many free videos for whole medicine. If any one of you want to see the free video of the whole lectures, you can very well contact us. Will be very happy to give you. And this screenshot, you can take screenshot, or you can contact our staff. And okay, details, I'll give you number also, don't worry. Okay. Now you can mail me for any feedback, or you can very well WhatsApp my staff for feedback or regarding taking the free lectures. A lot of free lectures are there. You will love to see, and I can assure you they are the best lecture in the world, covering A to Z. This is the WhatsApp number of my staff to get free. This is the India code, and this is the number you can very well note down. I will hold the screen for a few seconds. My email ID is there. This is my stuff. I hope you have written it. Friends, today I talk from A to Z, from basic concept. Now, any exam in the world you write, now you ask a question to yourself, are they going to ask anything beyond what I taught you? No way. This is more than enough. Knowing basic concept is the most essential thing if you want to get a grand success. Okay. So one more thing, not only you should know basic and how to study also. Sir, I study a lot, I study for 10 hours, but I tend to forget, I am not confident, not going high. Don't worry, I'll tell you how to study only 2 hours per day to top in any exam. Exam is nothing but recall of memory. I'll guide you. What I said, you use spec the way I use spec. Quite a you may be using spec. Suppose you misplaced your spec. You can't read newspaper, book, TV, movie, nothing. Why? Specs are not there. If you put on spec, you can do anything. Same thing with basic concept. If you don't have basic concept, you will never be able to perform in any exam. So friend, make your basic concept very strong. So whenever I take a class, like I have taken one lecture on HIV, you can very well see. I included all these subspecialties. After that, you don't need to read any book, any notes, nothing. Everything is given and you'll find, oh, I'm fully saturated with integration. The way today I integrated physiology, pharmacology, everything integrate. That is what is needed, and for that I've got lectures for you. If you want to see, you can very well contact my staff. The next lesson discussion will be on 31st January 10 as the time. Topic will be ECG, arrhythmia and pharmacology of antiarrhythmic drug. This is again one topic not known to 99% students, are not very comfortable. So you can very well join us and please do give feedback. And this is Minnie Harrison, very popularly. Minnie Harrison. Do you need to read Harrison? No way. Harrison is a very vast book. You need a summary. Minnie Harrison, this is available on Amazon. Okay. So I hope you enjoyed. My aim is to convert you from a simple star to a moon. Okay. I want you to make like eagle. Eagle can fly above the sky at the minus 45 degree to plus 45. Idea is to give you the best education the way A to Z. You don't need anything more than what I taught you. You are fit to write any exam in the world. I want to make you a car like this, premier car for the premier students like you. Okay. Do give feedback and don't forget to join on 31st January. Do tell your student, your other friends, colleagues, juniors to join to read about ECG, arrhythmias and anti-arrhythmic drug. I'll wait for your mails, okay, and for your feedback. Thank you very much. God bless all of you.